Welcome back to session 5 of day 2 Rhythm Interventions Online 2024. This is another live case session, and we're still sticking with the theme of old-fashioned electrophysiology, and here we'll be focusing on scar VT based on lines of block. And for this, we're delighted to have a live case from University of Arizona College of Medicine in Phoenix, the US, with case operator and RIO course director Roderick Tung, who never lets us down, always produces amazing sessions. Before we join the center, let me introduce you to our panel. I'm delighted to welcome Hari Krishna Tandri from Nashville, Usha Tedro from Boston in the US, where I flew from this morning, actually, Usha, and then Wendy Su from Aura in the US. Thanks so much for joining us, you three. But without further delay, let's join Roderick in Phoenix, first of all. Rod.
Hi, Professor Schilling. Everyone just confirming sound, and you can see us?
Or you can see and hear you perfectly.
Wonderful. Well, I know you're a fan of Phoenix, so we're going to keep the good vibes going. I want to introduce just the people in the room here before Dr. Martinez. Jake Martinez is our second fellow ever at Banner University Medical Center, and he's our senior fellow, so he'll be introducing the case for us. We've got Dave, one of our techs here. Courtney, you can't see. 2 other nurses in the back, Casey and Caitlin, and we've got Dr. D playing the hits and anesthesia behind us. We're under a general anesthetic right now, and in one of our 3 EP labs here, and we're presenting to you an ischemic VT case. So I love the panel, and let's have Jake kick off first.
Sure. So this is our case of a 75-year-old history of ischemic cardiomyopathy, EF's 15 to 20%. Patient's got an apical scar, seeing hypertension, diabetes, and he was transferred here for VT storm 4 weeks ago. Underwent endocardial epicardial ablation at that time. It was noted he had a calcified LV thrombus of unknown age on CT. Therefore, initial goal was to perform an epi-only ablation. VT was induced during that ablation with a right bundle superior axis with a cycle length of 320 milliseconds. Epicardial mapping was done and revealed a focal breakout, but VT was not terminated with ablation in that area. So we decided to do an endocardial map, revealing a line of block on the apical lateral wall of the LV. Voltage showed apical inferior and apical lateral scar. Mid-diastolics were seen near that line of block. And so when we put our ablation catheter, we had a bump termination of the VT. Impaired ablation was then done in this area, and VT was non-inducible after our bump. So here we are today. The patient returned with recurrent episodes of VT, requiring ATP, 16 in total, and 1 episode of shock. Here is on the left is the VT from 4 weeks ago. And you can see on the discrimination vector from his device, slightly different VT when compared to the recurrent VT since he had his initial ablation. On the bottom left panel, we have our VT from his initial ablation 4 weeks ago, right on the superior axis with that cycle length of 320 milliseconds.
Great. So just some comments here, because this is our own recurrent case. You have to approach them differently. And as Dr. Martinez just said, we had a thrombus in the apex that was age indeterminate. And that's why for that case, and the patient came in storm, we did an epi-only apical approach. And that has been shown. I think Jason Bradfield even published a paper on that. And even in the setting of thrombus, if it's laminated, it's fine. So we had a high threshold and we're hoping we can get it only epi. And then we couldn't terminate it epi. It was kind of a focal breakthrough in a RAP pattern. So we had to go endo. And we did see this little calcified thrombus. And we did minimal endo ablation just to get rid of the VTAC, but it bumped and it went away. As Dr. Martinez also showed, the electrograms look a little bit different from the one. It's a little bit faster, 20 milliseconds faster. And then there was a RSR prime on the one now, and it was a QR before. So we do like to look at those electrograms, just flipping back to that. And maybe even the faculty want to discuss, but Frank Bogan has one of the only papers looking at the mechanism of recurrence, and it was in 2013. And is it the same darn VT, or is it a different VT? And they actually showed that most of the time you're about 6 millimeters away from the previous lesion set. And maybe we just didn't fully address it, or maybe it wasn't transmural enough. But maybe we can just get the panel talking about maybe how much weight we put into the intracardiacs and if you approach it any differently. But our plan was to do an endo approach only, given minimal epicardial substrate, focal breakthrough patterns. We didn't see a lot of lines of block on the epi, and we did on the endo, which we'll show you in a little bit.
Because, I mean, Rod, often you kind of gut feeling know that you probably didn't get it. But on this previous ablation, it sounds like you had a really good diastolic potential. It bumped, terminated. You were able to ablate there. It seems really disappointing that this has come back. I suppose you were conservative because of the endocardial thrombus, but it seems like you've been pretty unlucky here. Let me ask Wendy, how would you manage that endocardial calcified thrombus situation? Would you go epicardial, or would you be anxious about going endocardial? And what would be your strategy in this situation?
My approach is exactly the way that Rod kind of described what they did. We can avoid going to the inside and disrupting something that we're not sure of the stability. Then that's preferred. In this case, he did that, and there wasn't much on the epicardium. And given the urgency of the situation, I think it was safe to have proceeded to go to the endocardium as they did, especially if there's calcium involved. That implies that there's some chronicity to it. The bump termination and the recurrence, I would say, is not terribly surprising, especially if ablation was limited at the time, especially if it were a large area of substrate. We see this a lot, even in people who haven't had prior ablation, that there are multiple different circuits that can evolve in that substrate. So you may have affected one, the active clinical one at that time, but that doesn't mean that you can prevent the others from happening. And I think that that's probably what has led to a subtle difference in the morphology on the 12 lead as well as the EGMs. But I would say I wouldn't give up hope. I think that this, it just tells you that you're in the right place. You just need to do a little bit more. Just be careful about the thrombus.
Great. Any other comments on the intracardiac electrograms, and before we kind of tell you more about the case?
Harry, tell me, do you sign up to this, the concept that this is probably coming from the same location, just a different route, a different exit, or do you think this is going to be something completely different?
Yeah, unless there's been a change in what you did after the prior procedure, it's not uncommon for you to stop the amiodarone or change some management and whatnot. Generally, the VT that occurs shortly after the procedure is off the same cycle line, at least pretty close to it. If this is,
We'll have to try that first.
slowing in the cycle length or a change in cycle length is often that there is another circuit that wasn't addressed at the same time. The ablation was limited or very focused on one particular VT, and not enough to unmask another one, especially in this case where the mural thrombus was suspected and they wanted to minimize catchment fusion. Yeah, it could be either. It could be just a return of the same VT with a slightly different path, or probably another VT close to the same, scarf.
And that's great. And Anusha, there's always this tension between success and safety, and how hard do you try? How hard do you try and induce? What's your approach here? Do you if you got termination and you got good signals, you'd stop, or would you continue to try and re-induce and look for other potential drivers?
I think I would probably, in this case, it looks like the VT, I couldn't quite see the cycle length, but it looks like it's quite slow. So I think that trying to re-induce is very reasonable in this case. I think you always have to watch the patient and see how they're doing with the procedure, and keep the clinical VT in mind. The one thing I would worry about in this case is when the thrombus is calcified. Like, I don't worry so much about embolic events, but I worry that there's some critical substrate that we're just not able to put our catheter on. That may be part of why it recurred, that maybe we took care of some little part of the critical substrate that's peeking out from the side away from the thrombus, but maybe there's something critical underneath that calcified mass that we might not be able to access as easily.
Yeah, fair point. Rod, where are you at the moment?
Yeah, so let's catch up a little bit here. Why don't we go to the ICE screen, just so we can show the substrate. We've actually been loving ICE even more as complementary to MRI, because sometimes even peri-aortic scars, subtle ARVC, accordion, free walls. You can see better on ice than MRI. Here you can see we got a large anterior apical infarction. We've got a grid catheter in there. We've kind of given away that the patient's probably in VT right now, but I didn't want you to know that right away. And then you've got that apical infarction. We can see there's a little bit of calcium just at the tip of it. And you can see it's kind of this laminated echogenicity, and at the lower portion of the apex, there's a little bit of calcification. We did find further, because he came in storm, that he's known that for several years. And the procedure was done over 30 days ago, and he's been on Eliquis. So we feel better about it. There's nothing mobile. There's nothing that's flapping in the wind. This looks like it's sessile, calcified, and obviously calcium does indicate chronicity. So what we want to do is show you how we first started with the map. Because we had gone epi, there wasn't much. We were going to just do an endo approach only today. We'll save the epicardial for the AFib later today. And what we're going to show you here is the voltage map of the ventricle. So why don't we go to the mapping display? Great. And that's at your standard UPenn 1.5. So there is a very extensive anterior apical infarction. So homogenization, if you want to start there, it's going to be a long day. And again, homogenization is the gold standard, I would say, across all labs, because it's probabilistic, it works. The substrate's somewhere in the scar, and that's where we've been trying to refine homogenization to try to figure out where physiologically is most prone to reentry. Let's switch that to an isochronal late activation map. And here you can see your eyes immediately go to the area of crowding where you have a line of block. And this line of block is beautiful. You can see the purple late region. And remember, 10 years ago, we were looking at the late potentials, only post-QRS. Now we care about the genesis of the late potential. How did it get there? It's a late arrival, but it's not the mechanism of the conduction slowing, which is the slow pathway for VT during sinus rhythm. So here, if we even propagate that, let's go ahead and propagate that. You can see that it ends up in this late pocket, and it almost has, there you go. So you can see it's very wide. And again, never look at an electrogram, never look at a map without electrograms. So maps are created by electrograms, not the other way around. Casey, why don't you show on review screen? Let's go to review screen, show them some of the signals that we saw. And we use this linear catheter because still we like to see wavefronts. And there's an example of a late potential right there. And you can see we're mapping in left bundle branch block baseline. Patient has a BIV. We can discuss this, what is the optimal wavefront, and we should discuss it. But most people will maybe keep on BIV, but maybe there's collision. We think it's all depends on where the substrate is. The closer you pace to the substrate, the more likely you're going to unmask a line of block. This is the basic principles of differential pacing, and we've not really employed that into VT. So here you can see that there is a nice line of block. Nathan, why don't you draw that line there? And then Casey, why don't we show a couple other electrograms there? And apical wide late potentials, great. And just come over there. So you can see there's these really small far field signals that are widely separated. Casey, just measure how wide that is, the separation between that and that. Great, that's 220 milliseconds. That is 2 times around the right atrium. So we should marvel at the extent of conduction slowing there is when you have lines of block. And we always think about late potentials, split potentials, fractionated electrograms, lava. The only unifying theme is a line of block with variable wavefronts with variable collision around these lines of block. And when you're pacing further away from a line, it looks more collided. And when you pace close to it, it's wider. So we at baseline already have these ridiculously wide fixed lines of block that we don't feel like we need all these other wavefronts to find an abnormality because it's already apparent. So we start looking at other wavefronts when it is not apparent or it is not overt. And that's when we start thinking about concealed lines of block, not necessary in this case. Okay, we're going to go quickly now to the VT. And I'm just for the sake of it, because the blood pressure is dropping a little bit. We got 5 of dopamine. And as we were moving around with the grid catheter and we were trying to refine it, we actually went into VT. And here you can take a look, all right, at our electrograms. Why don't we go live screen electrograms? And here we've got the grid catheter roving around. And here you can see we set all of our window up. If we can just support that just a touch, Dr. D, maybe one push. And actually, why don't we give some atropine, please, Dr. D, as well. What's our sinus rate? Measure our sinus rate, please. Our sinus rate is what? Wonderful. If you're going to die, the sinus rate should not be 66. This is a maladaptive response to vasovagal response to VT. So we're going to push some atropine. The blood pressure is 75/50, and we actually were 120 before on just 5 of dopamine. And we're going to give a little atropine and see if that gives a boost. But we've had the luxury of mapping this VT here. Now you can see live screen EGM, please. We like to window at QRS onset to onset. So the Bill Stevenson QRS onset is the 0 point, and we can find earlier and earlier and find 30 to 70. Here you can see the presystolic electrograms on the grid. We're probably minus 30, minus 40 already. So this area should be where purple is, where purple, white is the breakout. Okay, and if we look at the 12 lead in real time, Casey, just scroll up to 12 lead. Great, you can see that the VT we've got is kind of this indeterminate apical VT, QS across the precordium, superiorly directed. That's an inferior apical exit. So the exit is on the inferior surface of the heart. So if we tilt up and go to map real quick, go to the mapping, great. Tilt up, Nathan. The purple white will be on the inferior surface of the heart. That is what we worship as the exits. But the machinery or the isthmus lies above it. How does it get to purple and white? And we start mapping around it, and we're looking for dark blue. Then we're looking for light blue. Then we're looking for green. Then we're looking for yellow, and green and yellow is in the 50%. So take a look at what we find here, and let's show electrograms in real time. So Casey, go ahead in real time. So I've got presystolic electrograms is what we've got here. We're going to just counterclock this up here and go into blue. That gets earlier. Okay, so that's beautiful. And remember, we did quite limited ablation on this just to get them on a storm, knowing that we did an incomplete job. We're going to fill in and keep going real mapping here. We've got dark blue. We've got light blue. Dr. D, we gave atropine, 1 milligram. Do we give anything more or no? How much? 8 of dopamine. Good. So constant dialogue between the anesthesiologist is critical to running this mini ICU. Do we have a blood gas? Okay, our blood gas started with a pH of 7.38. We made this observation that we often hypoventilate patients. So they already start behind the 8 ball with respiratory acidosis. Then you compound it with metabolic acidosis and you might get PEA and hemodynamic collapse. So we're going to test the blood gas right now because if it's very acidotic, we're going to get them out of VT. And if it's not, we'll keep proceeding. But right now, clearly we already have enough. What was that? The pH is 7.45? Okay. Okay. But that's in VT, correct? Okay, so the pH is 7.45 in VT. So we're going to keep going. Rather than relying on your gut instinct, we're looking at real-time left atrial pressure that you can see in yellow, which is 11. We've sometimes have seen people go with CV waves with MR up to 60, and those are patients that can't tolerate VT. But right now we think we can. As we move here now, go mapping screen, please. We're light blue, and now we're going to green. So this is really a great case where we can explore the circuit, which sometimes we don't always have the luxury of in real live VT cases. Here you see the electrograms get low voltage and go live screen electrograms now, and let everyone see the beauty that is VT. And here you can see some mid-diastolic electrograms that are fractionated. If you look at the bottom, the blues, you've got even a little bit of splitting there as it comes through. So this is kind of getting into that blue-green region. So this would be approaching the 50th percentile of TCL with our color scheme. And we'll probably go ahead and entrain that because we should. Why don't we go ahead and try to entrain B4C4, bottom blue. Bottom blue. Yeah, 20 faster. 20 MA is what you're going to need for that electrogram. And let's go ahead and see if we can drag this tachycardia with us. Stay, stay, stay. Looks like you got something stable, right? And off. Great. That looked pretty good. Why don't we start with the first principles of entrainment mapping? Go to the 12 lead. So let's go to the review screen. EGM, please. Review screen EGM. Great. 12 lead. Let's step 1. Is it concealed? Yes, it is. Concealed fusion. There's nothing overt. Step 2, go to intracardiacs and look at your stim to that EGM. Good. And measure that stim to the EGM a little further down the road. Casey, it's the mid-diastolic one. Keep coming down the road there. Keep coming. Good. We're working it over. Okay. Somewhere in this area, it's going to be even earlier than that, about 360. What's the cycle length of the tachycardia? 390. Ooh. So that's actually not a bad thing if we're entrained. We can look at the exact electrograms, and short PPIs, because we're pacing at 20, are not uncommon because you're actually getting a larger virtual electrode and penetrating deeper in the circuit. So that looks pretty good. We like the concealed. It almost can't be anything else here because you can play that this is a bystander game, but I don't think that mapping here would support that theory at all. We're going to counterclock a little bit upwards further, and there you can see, go live screen EGM. There we've got early diastole. So this is definitely brunching at the diastolic buffet. And we've got the whole thing there. Okay, so that's early diastole. Why don't we go ahead and train that, Casey, C1B1. I think Henry Shaw would be proud because he likes to entrain all the different parts of the circuit. We typically just rely on a lot of activation mapping, but I think it's beautiful for a case when we can put it all together. Go ahead and stay. Go live screen EGM, please. Good, and off. That is beautiful. And you can see the stim to QRS is longer. It's getting that EGM. Go up to the 12. Let's go to review screen now. Great. The 12 shows the long stim to Q with concealed fusion. Come down below KC and get your PPI there. And then Nathan, why don't you prepare to propagate? Let's just show that. Great. And that's 390. Great. And everyone go to the review screen and everyone can see it. 390 equals 390. Why don't we go to the math itself? And Nathan's going to show you the VT. It is coming down the anterior wall, coming down to the apex, lift up the nose of the apex, and it busts out. There's your breakthrough. So if you're going to ablate the exit all day long, it's very wide. We'll come back to talking about circuit characteristics, but you've got the isthmus on the nose of the anterior septum, and it comes down. Okay. Why don't we go for a panel discussion of what else you'd like to see? Because I think we should get the patient out of VT and go for a termination. And then we're going to work backwards on this, which I love. Then we're going to go compare this to the ILAM and see if these truly were lines of block. So while the panel discusses, I'm going to get the ablation catheter ready to go in, unless you feel like there's one more thing you'd like to see or you think the mapping is not adequate.
I think it would be very difficult to see better mapping than that, in honesty. But I'm really interested to hear the panel's view. Usha, do you think that this is, have we proven beyond doubt that this is the responsible circuit and ablating on that isthmus is going to fix things? Is there anything else that you would add?
Yeah, I would say that the data would suggest that the first site of entrainment would have more than a 90% chance of VT termination based on the response to entrainment.
And how it's fascinating that this man's got an endocardial scar and calcification, yet we've been able to map the entire circuit. None of it seems to be epicardial or subendocardial. Is that common in your experience?
Yeah, I think this question comes quite frequently, especially with apical fogs. There's always an echo read that says there's thrombus in the apex, and we're always faced with the conundrum. We don't really know the patient. The patient has been transferred from elsewhere, and you have to put your catheter in. You always felt with this dilemma, what should I do? But in my experience, it's just been difficult to find this epicardially. You just don't see the circuit epicardially. You just see an exit. You often end up not getting all the metrics that you need epicardially, end up ablating there just because of the lack of access. But coming back to the question of the dense the thrombus is layered on top of almost non-viable fibrotic tissue. And it's usually the edges of that are the ones which are critical isthmuses or the ones that propagate VT. It is true that you will still be there in that vicinity. If you have a clot, there is no way you can avoid that, especially with the cardiac motion, especially in VT and not being able to control.
Adaptopa.
And you got someone else, it's about who drives the catheter and everything. But it is true that the dense portion is probably not involved in the VT circuit. So the dense scar. And that's usually where the thrombus is. So if at all possible, I would look for endocardially, and you would always find it in a location where you can ablate. It is rare. It is sometimes possible that you can't get to it just because it's beneath. Especially in bad patients, you see that sometimes. There is scar and there's a circuit underneath that you really cannot get to. You just see far field.
Yeah, so that's a fair point that the thrombus is often covering bits that aren't relevant anyway. Wendy, one of the audience has asked about approach, retrograde or antegrade. What's your strategy knowing where the scar is? Does that
Casey,
affect
entrain
your
from here?
approach, or do you go both routes, or how do you manage that?
20?
Increasingly, it's a good question. I've been going antegrade regardless of where the location is. In this instance, either retrograde or antegrade would be fine because they both can kind of direct you there easily. I wanted to kind of
All the way down.
add to Hari's comments about the
Bystander. Yep.
and actually Usha's comments as well. I think that they're mapping in the vicinity of where that thrombus is
Bystander.
located, that calcified portion. And I think it's encouraging. Usha's comment about the worry that you may not be able to penetrate through the calcium to get to the area of interest with RF is valid. But the fact that they were able to capture with high output pacing is encouraging. And so I'd say I agree with Usha. Like, I think if they go on there as their first ablation site, they're likely to lead to termination. I don't think that will mean he will be non-inducible. I think that there will need to be more ablation that's performed additionally to kind of modify the substrate. You know, I noticed too that the exit of this VT is less rightward than at least the description for the first one, which kind of just speaks to they probably got one exit and then it's just going a different way. But this is a great case.
You've timed it perfect because I think Rod's now getting close to that diastolic pathway. Is that right, Rod?
Yeah, so appreciate the comments. I would also like to do something different that we don't see as well. I like the idea that Usha says with entrainment, you're likely to get termination. But again, that's assuming all the circuits have similar width and size for a given electrogram. Because think about it, entrainment mapping is a low density mapping strategy. You get one spot, it looks like it's in, but you have no idea how wide the isthmus is. Go back to the map there. We have the luxury here of looking at how broad the exit is. So purple and white is where the QRS is. This is why exit site ablation is not typically effective and you have to do more than you need to. So if you were to cover this entire circuit, and we can try it, we can do one lesion in the purple and it would be QRS and it will not terminate this VT because you can see it's very broad. It will go around it. But if you move up closer into it and go up, we would try to clip this or transect this. Nathan, just tilt the nose down. We would try to transect at the narrowest neck, which is what we always do in every single reentrant. We would probably try to find something there up in the grain, and that's more likely to get a single burn term with elimination. So I would just say it's so rare that we get the luxury of dissecting a circuit live in a 2D circuit with a mappable VT assisted by atropine here and an 8 of DOPA with a pH of 7.4. We checked it again, so we feel good about continuing the conversation. Something I also wanted to do was try to debunk double loop reentry. So what we're going to do, and Takuro Nishimura published a really nice paper in Heart Rhythm, is try to entrain from both outer loops. And the real question is, are both outer loops part of this? Okay. So Casey can show you that we just entrained on the upper part. Let's go in the mapping there. So let's go to Casey's screen, which is EGM review. Great. And you can see we did an entrainment here. There's an electrogram that still sits out during entrainment. It is concealed, but there's one that sits out just underneath the midpoint of the QRS. So the PPI should not go to that electrogram. It should go to the following, which is 650, which is extremely long. That would be like a bystander response. And why don't we go to show where we did that on the map? So let's go to the map there. And that we did that on the right hand outer loop. So even though this looks like a double loop reentry, it does not mean that that is a requisite part of the circuit itself. Now, if we can maybe get, and this is a very large ventricle, to the other side, right here, we can try to entrain from this side, the left-hand loop, and see if that is more in. So why don't we just do that? This is further away from everything, but let's just try before we go for some elimination. Here, we're up at the entrance. Let's go real time. We're just moving around with our ablation catheter. Okay. And let's see if we can touch down. There we go. Why don't we try to do it from, that's really far from the circuit. But let's just try it. Proximal. Let's try proximal. It's right to the side of purple and white. Go ahead. Live screen. Looks like we're not getting it there. Okay. Off. Let me get better contact. Now try distal, Casey. Let's go to live screen AGM, please. Good. We're intermittently getting some fusion. Okay. It's maybe MESing during entrainment. Off. We didn't capture there. Okay. Let me try to come up a little bit higher. The area that is very septal is really hard to access. But the point is that we've already shown that that one right-hand loop is out and it's a bystander, which means that it could be that it's a single loop reentry going around here. This is more of the exit. We've already kind of done something there. Does anyone want to see if this exit site ablation works, or do we want to go to the money? Because here you have
we
a
all
little
agree
live
with
screen.
you.
Here we
If
have
you go for the money, do
QRF.
what you think the best thing to do is,
Okay.
Rob.
Right. So I think what happens is all of us, this is the best site we can get. So if you look on live screen, Casey, why don't we change that from red to yellow? We actually joke in the lab, the only worse color for red on black is black on black. So let's make that yellow. There we go. Okay, so we're not going to do brown, red, or black. There you go. So you see, that is what Josephson and Miller called SOO, the best pre-systolic. It's clearly early. So if you get this, everyone's excited. But then if you actually have the context of the map, this isn't good at all. All right, so why don't we go up here to green and see if we can just get us out of VT and see if we can get it in one burn. But again, you don't always have the luxury of having this, in all cases. Why don't we also show on ice how we're swimming in this ocean that is the ventricle? Let's go to ice live. You could see how large of a curve we have to be able to try to contact this point here, and how the grid, which is so good when it's prolapsed, has better contact than any other catheter in the basal segments. The grid is one of the few catheters actually that maps the base better than the apex of the heart, whereas these linear catheters do better that way. So I'm just trying to struggle to get contact because the grid is a larger curve. I'm going to try to put a little bit more body into this and then see if we can sweep down here and get something that's mid-diastolic. But you can see we're kind of swimming in this ocean, and we're trying to get more than 1 gram of force on this. Let me reverse here. So I'm on my D curve. We're going to reverse here and go to the F curve. Okay, and then hopefully not terminate VT.
And what she's
Rod,
in there, Rob?
Perhaps a comment.
And we've got a large curve agilis into there which is steerable. And sometimes you might not have the luxury. So there my ablation is in the pre-systolic range. Most people would be kind of happy about that ablation signal. Go to live screen, please. Great. So you see a little pre-systolic. Let's roam around the circuit real quick. And then here we're pre-systolic. Let's see if we can come up into this area here and get better contact. See how it says 1 gram of force? This is the real challenge for this large of a ventricle. There was a little touch of mid-diastole. Let me advance more catheter in. There we go. There we go. See if we can let out there. So we're basically almost hubbed with the catheter in there. We've got some diastolic signals. There we go. And then I think one subconscious or unconscious bias is there's all this data about near field. Near field's the best to predict termination. Absolutely. But near field is also contingent upon force. So we typically don't like to come on unless we have a really sharp electrogram. So you can see we're going to try to, proximal is not ideal. Go to live screen EGM, please. Proximal is not ideal, but distal is pretty good. And if we come up just a little bit higher here, so this is kind of the neck of where it starts getting broader. So I think there's a good shot at this terminating with 1 lesion. All right, so why don't we go ahead and propagate the VT in relevance to where the catheter is. And let's see if this is where it would come through. Good. So there's really not many places it would go around. So I like this spot. I say we go for it here. We got 7 grams of force. Because my force is single digits, I'm going to come on at 50 watts. I'm also less worried about a steam pop because this is such a thick scar. So let's come on at 50 watts here. The pressure is kind of in the 50s range. Great. We'll come on here. And our force is not amazing. Look at the electrograms. There's 10. Okay. Just stay on. We're going to commit to the lesion here. And then we want to monitor to see if we can see it. Okay. It's a very large, long circuit, but this is the narrowest part to it. I'm trying to image to see where it's at. The local electrogram looks like it's relatively diminished. So the question is, could it be propagating next to us there? Good. And this, we're going to commit to the whole minute here. And at a minute, I'm going to extend up just a little bit here. Off. Let's go a little bit higher. There you go. That puts us in higher range. I think this is a contact issue because I'm single digits. There's some
I think you've
fuzz.
slowed it.
It's not great. Yeah, we slowed it just a little bit.
Well,
Here's
I
7.
think that's promising.
Okay. Yep. It's an issue of time here. Now we got 18 grams. Do you see an electrogram? Why don't you gain up? Actually, this is great. Go to live screen here. I love that. Go to live screen. You can barely see a diastolic signal on ablation distal. Go ahead and gain up that, Casey. Blow that up 1. Blow it up 2. Okay, let's see it. Too noisy. We don't want to gain it when the whole thing has come down a little bit. Okay, so this here, if we look on the mapping system, go to the mapping system, we see it better on EnSite. You see a diastolic component there on EnSite, but you don't see it as well here, so there's different filtering as well. So we're integrating all of it. Let's just try it here, 50 watts. 16 grams of force. Slowing here. Did the catheter move there? Or take a deep breath? Looked like it moved. It dropped down a little bit. Let me just kind of clock back up. There it is. Catheter dropped. I just put it back up. How much did it slow? 60 milliseconds. We're at 460 here. We're back up at the top. There's a little bit of catheter instability. It's slower. Propagate the VT and see where it could be going around us. And the electrograms are so small that they're intramural. If you have to gain it that way, it's not actually on the surface. So in a way, it kind of is like a 3D VT. So maybe what we need to do is get a better vantage point in here. I'm going to clock a little bit here. That's burn number 2. Okay. Off. Okay. Let me come up here. Now, this is just a very near field signal, but it's a lot wider. Okay. But there is this focal breakout right there. So while I don't love it as much as the others, we've tried the earlier ones, but they're probably further from the surface. That's the issue. Whereas this is such a nice near field electrogram. Oh, and look at that. That's what happened last case.
Yeah. I was going to say,
So I think
the
what happens is
yeah.
it's so much more near field, right? And that's
Yeah.
the whole idea.
Longer
that
time to
there's
propagate
a layer
through the
of
distal.
scar. Correct. And then where it kind of breaks out. So in a way, we said this is a 2D VT. It probably is actually a 3D VT because there's definitely the loss of electrograms, but you see them really far field. Why don't we go ahead and take this moment to break and let's talk about the lines of block real quick. So how much time do we have, Professor Schilling?
So we've got another 15 minutes. So you've got plenty of time.
Perfect. Okay. So let's look at that VT circuit real quick and draw where you think the isthmus lines would be, Nathan. And you can even propagate it and draw it that way too. Okay, there it is. So everyone can see the mapping. Can you change that line color to white? It's on black, so I bet you they have a hard time seeing it. And then the last 5 minutes, we'll re-induce it and try to terminate it. But we can have this discussion because the whole segment is about lines of block and fixed lines of block. So on the catheter where the termination is, clearly it's fractionated. There's a multi-component electrogram. That's fine. But there's kind of where we think is the isthmus. And the real question is, can we find the isthmus and sinus rhythm? Let's go to the ILAM and keep those lines and flip over to the ILAM that we had with the trideca. Okay. And this is where you have to do the analysis and say, okay, where is this, right? So here you can see the latest is over there, and there's a line of block here, right? And so it's not a perfect match, but it definitely skirts over there and kind of comes around that area. And then you have another line of block inside, higher up, right up in there, and extend it up there. Yeah, can you take away those lesions? Yep, and you can trace the line of block up. Yeah. Okay. So this is where I would actually want to see if there are actually lines of block in this area that between the isthmus. And here you can see if you propagate that coronal map here, and we don't have much density there on the left is the issue. Okay. So why don't we go ahead and map with the grid in this area, and let's let the panels just start discussing a little bit about some of the limitations or strengths of what we might have just done. I'm going to map the grid right in that isthmus and see what that looks like in sinus rhythm, because I think that's the real message is, what does the isthmus look like during sinus rhythm?
Rod,
Great.
could you
Well, let me
indicate
know.
where the thrombus is on the map also? Maybe that would be helpful.
Where was the what?
Where the thrombus is located
White is the
on the
VT.
map.
Oh, yeah, on the map. That
Yeah.
would be more challenging because we're not using CartoSound, right?
Mhm.
This is using Nsight, which the next integration is there. But what we could do is there's the thrombus, but it's a tiny one. Let's go live. There really isn't a thrombus of any true significance, I think. Let's go to live ice. There you see, right? The lower part of that Usha looks like there's a little calcification, but it also could just be calcified infarct there. But you see how there's that little C-shaped. But it would be good if we could integrate it, which is actually not in the current version right now. Okay, that's 10 minutes.
So, Usha, do you have any experience of using PFA? And what's your opinions of using that for VT?
So we haven't used any PFA for VT. I don't think there's a couple of sites, probably Rod knows more about this than I do, that are using a FARA. Do you have a FARA there, Hari? I think you might have it as well. No?
No,
Yeah, no, I don't know that we have.
Nathan, where's my grid?
So I would say that there might
Where's
be
the grid?
some hope that that PFA would help, or maybe ultra low cryo could help in a case like this. Because I wonder sometimes if when we get great electrograms and we don't get termination, it's one of these instances where achieving actual tissue destruction with radio frequency is really challenging. So you wonder if it's not the best energy to create the lesion in that place, especially the more dense the aneurysm is.
Yeah, I mean, good point. And I mean, there's some concerns about, PFA may not penetrate as deep, but it seems to get better through scar. Harry, do you have experience of PFA in the atria or the ventricle at all?
Yes, I have experience in preclinical models at PFA in native porcine heart and also some infarcted myocardium. It does the job, but there is significant amount of stunning depending upon how much energy you use. And I do worry about using that in ischemics where they're already marginalized with function, and then you have PF lesions and you'll get significant ventricular depression. So unless we have a very focal application where we can control the energy and not just out of the box 25 amps or 15 amps, it's going to be a little tricky. Also, given the issues with coronary vasospasm, you have to worry about using PF in the ventricle. Just to build on what Usha just mentioned about, the ultra-low cryo just definitely seems to be very promising. One, because it just takes away the issue of contact, this loss of contact that happens when you put the RF catheter, is always slips away. You have to put a lot of catheter, especially in these big infarcts, ultralow cryo is definitely promising. We just did a case and it was quite useful to use that to create durable lesions.
I think
When-
the
do you-
latest, there's a catheter in development specifically for VT by Field Medical. And I think that has shown great promise. Some preliminary data about that was shown at the VT symposium. That could be a way to get around this. But I think, I guess getting back to the lines of block that were being drawn. So one set were clearly during VT. The other, I believe, is an estimated isthmus based on isochronal crowding. Is that right?
No,
I
one
think
of
that's
them,
right.
the yellow is actually the VT isthmus,
Uh-huh.
right? Is the VT
And
then the black are the
Okay.
ones that we saw during sinus rhythm. But we didn't really
Right.
commit a lot to this isochronal late activation map because we kind of just ended up in VT when we started mapping.
right.
That's why what do
Right.
we have? 7 minutes here? That's why I really wanted to see if I can try to get in there and show some of those.
Yeah.
But the electrograms are definitely abnormal in those regions. And again, to flash
The
it,
point
there
distribution was
is.
reasonable.
It was. And again, that could be the limitation of one ray front. But if you were okay, let's just play that for Nathan. Just show this. Good there, right? So here's the question. Oh my God, that's actually even more beautiful. We didn't even just see that. You see that line of block that's transecting the isthmus? It looks like it's an H shape. We actually think that all of them are H-shaped. Why? Because the middle is hyperbolic. So that black line could be a depth boundary, and that is evident by the electrograms that we could not see, but we could see some far field grid. So what it's doing is we all understand the lateral boundaries on 2D, but then there's something pushing down and constraining the isthmus like the waist of a cylinder. So it proceeds through the lateral, but then it comes underneath, and we didn't even plan that. That's the H-shaped boundary that we've been thinking about with a hyperboloid idea. The one to the right clearly seems like it's not necessary for this circuit. It might extend further and actually shape the way that the exit funnels out. But it'd be great to kind of get into that spot to see. So I guess the better question is with the panel, what do we have, 4 minutes or 5 minutes now? 4? If you'd rather see
5
us go
minutes.
back into VT and try to terminate it, even though we've already bumped and we've seen it, or would we rather see some kind of like lines of block demonstration and try to straddle it? So it'll be a choose your own adventure here.
Lines of block.
Okay. So let's see if we can get back in. We had a very anterior stick that we took from last time, which has actually complicated this in general. Actually, let's show that because not every live case should go perfectly. Go to ICE Live, and that's why there's been a little bit of a struggle behind the scenes here, okay? So here's the ICE stick for the fellows, and you could see here, let's just kick all this off. And we should have, and the lesson is if you have a stick that's not ideal, then just stick again. Because sometimes you don't want to have to get into a situation where you're just, you're at mercy to the stick there. So here you could see there's aorta, and this is for the fellows in the audience. And right when you clock past, there you can see is our stick. And in general, we like to encourage an anterior stick. And you can see the sheath is right across it there. And then if we open up the atrium there, you could see it's freely flopping. So this is a very anterior stick. It's probably too anterior because as we're introducing the grid, it actually rubs up against the anterior wall and gives us a problem. So I'm coming in with a linear catheter, trying to watch this to see if we can come across here, and then seeing if we can get in. And if we can get this linear catheter in the last couple of minutes and see lines of block, that would be great. Why don't we also go to the isochronal late activation map? Okay, a second. Good, and go to the map there. And maybe we can even look at some of the electrograms that we were seeing previously. Why don't you show some of those electrograms, Nathan, of what we were seeing in there? There they are. That's perfect. So if we can take a look at the mapping now, and we don't always have to go back and remap it, you can see on the mapping system, what's most important is look at how widely split those electrograms are in the isthmus. So you see, you naturally already have 2 tram tracks separated by a line of block. So that would probably already be sufficient. And that was a linear catheter you could see this wide separation of the electrogram. So that is why we're now thinking facile VT will be a prospective study to just burn around lines of block within about 2 centimeters, because we found that if you were to do a Burns line of block and you say, okay, I'm just going to burn within here, you would get this VT, even with one wavefront, and you burn around that one. And the other one on the right probably has other VTs here, because the entire ventricle is gray. So this would be a great way to start homogenization by saying, I'm going to target my lesions and cluster around the line of block on the right. Probably wouldn't touch the VT. It's another loop. I'll cluster it on the left, would nail it within the isthmus. And the one that there is crossing is probably the H-shaped line of block. So everyone can see those split electrograms. If you guys want to comment on that with the remaining 3 minutes.
Yeah, we've got 3 minutes. Maybe Wendy, can you just, what's your thoughts on that phenomena there?
No, I think the
Where's the
approach
right
and the description of the three-dimensionality is
Not
you know,
even.
pretty nicely explains why those splits are there on that same two-dimensional surface. So there's something that goes deeper. Probably if you could be a layer or two deeper, you might record signals that complete that that distance, you know, that shows up just on the one surface. I'm wondering if, you know, even, I mean, this sounds like a classic completed infarct case where, you know, most of it's on the endocardium or accessible from the endocardium. And I wonder if, you know, the epicardial portion was just too far away from where that waste ends up, you know, in this paraboloid kind of model.
Yeah. And Harry, any final comments?
Yeah, definitely. I think even though there is three-dimensionality to it, there are many points within the circuit in the endocardium where the electrogram takes a long time to propagate. And usually, you see that in on the ablation catheter, a very long fractionated electrogram, which is pretty much takes a lot of time to propagate in that region. And those, I think, would give you the same sort of a result as if you really hit this one sharp little electrogram that through a very small channel. So you also get the same bang for the buck if you get that slow conduction region, because it really depends upon that slowing there to sustaining the VT in the first place. So I think definitely there's something to be explored on the endocardium, even though it's a three-dimensional circuit.
Perfect.
Go ahead and induce.
Is there any very final brief words before we've got to finish?
I would just say the exciting part about this whole approach, and in this case, we didn't have a choice to not map in VT, but is that maybe we would be able to define these lines of block in sinus rhythm and ablate in sinus without ever inducing VT. It'd be safer for our patients.
Yeah, well, I think, Rod, I'd just like to thank you and your team for an amazing case. You haven't let us down yet again. I'm very pleased that the VT didn't stop in the diastolic isthmus, because I was beginning to worry that you'd faked all your cases. They were all so amazing. But thanks so much for a brilliant case.
Thank you very much. It's a really an honor for us to be part of this. Appreciate the whole panel and the entire RIO organizing committee. Thank you from Phoenix.
Thank you.
Great. Well, thanks to the panel. And there's a lot more to come on day 2. So see you on the next session.